Hi everyone, welcome to Abnormal Child Psychology. My name is Bree Cervantes and I'm the instructor for this course. So this is going to be our first recorded lecture of the semester. In the next few slides, we're just going to touch on a few things from the syllabus that I wanted to make sure I point out, but just to note, I'm not going over the full syllabus because I want to make sure you guys read that on your own. So we'll just spend a couple minutes talking about a few points from the syllabus, and then for the rest of the recording, we'll jump straight into some of the content for week one's readings. Okay, so this class is an introduction to childhood and adolescent psychopathology. And when we look at psychopathology in youth, we always do so using normative childhood development as our backdrop. So we're interested in looking at the different factors in a bunch of different domains, so biological, sociocultural, any of the environmental domains, always looking at how those factors drive psychopathology. So what things kind of are responsible for these deviations in normative development. So the way that the course is organized right now is the first 2 or 3 weeks or so, we're going to be spending more time just broadly looking at the different domains that we're interested in when we look at child psychopathology. And then after week 3, we'll move into discussing more of the specific classes of disorders. So we'll talk about anxiety and stressor-related disorders. We'll talk about obsessive and compulsive disorders, things like that. So again, the first few weeks of the course is really designed to just nail down some of the models and the theory, just so you have a broad understanding of how we actually study psychopathology. In terms of class format, so again, this is an asynchronous online course, which means that everything is totally online and there's no designated time for us to meet for the course. So we don't have a scheduled Zoom or Teams meeting to meet every week. Everything is self-paced, so you're just going to access everything here on Canvas. So every week, the lecture slides, this recording, any assignment that might be due, that'll be posted to Canvas every week per module. So every week is going to have its own module, and you'll just go in there and click and see what's on there. Announcements from me will be posted through Canvas, and I think they also get sent to your CougarNet email, so you'll be able to see announcements from me both ways. And then the other thing to note is that because we're using Canvas exclusively, that also includes messages and correspondence. So if you need to get a hold of me or the TA, who again is not yet assigned, but will update you when she is or they are, if you need to get a hold of us, what you'll do is you'll use Canvas Inbox, which is literally just an email function through Canvas. So hopefully you shouldn't have any trouble accessing it, but I think if it's on your desktop or if you're using it on a mobile application, there's a little toggle app that says Canvas Inbox. You're going to find this course section, which should auto-populate for you. You click on it, and then you send us a message. So you'll put me in the recipient, and you'll also put the TA, and you can send your messages that way. So again, we're not using CougarNet/Outlook email. Everything is totally through Canvas. And then the last thing in terms of correspondence is, although there's no weekly meeting time for us, there will be 2 office hours offered every single week. So I will have office hours Mondays from 11 a.m. to 12 p.m. every single week. And then once we have our TA assigned, they will also send out their regularly scheduled office hours. And that one should be about 30 minutes. So you'll get an hour with me, 30 minutes with the TA. These are totally optional, but would recommend you attend if you have questions or you want to talk to us. So that is the only link that you'll see for meeting, but remember it's optional and you don't have to attend. Okay, last thing to note is we do have a required textbook for the course. So that's this Israel et al. Abnormal Child and Adolescent Psychology textbook, 9th edition. The book is available through CTAP here at UH. I know you can also find it on Amazon or whatever, Chegg, any other resources you want to use, but I would recommend sticking with the 9th edition because a lot of things will come from the textbook as we talk and as we do assignments and exams. Okay, so the last few things to touch on from the syllabus before we move on relates to course grades and assignment deadlines. So, your grades in this class are calculated based on the assignments and the exams. So, in the class, we have 3 assignments and 3 exams. However, only 2 of the assignments and only 2 of the exams will count towards the final grade. So, I would recommend, if you can, to complete all 3 assignments and do all 3 exams. That way you have the most flexibility and you drop the lowest grade. If for whatever reason you're not able to complete all 3, whether it's the assignments or the exams, that's okay. And that just becomes the one that you miss, and that's the one grade then that we will drop. So because we have this policy of only 2 of the 3 assignments and exams counting towards your final grade, we don't have any makeup assignments, we don't have any makeup exams. There are no makeups in this class. And again, that's specifically because you have the option of dropping your lowest assignment grade and dropping your lowest exam grade. So again, best case scenario, complete all 3, but if not, that's okay, and that's why we have this flexible policy. There are also going to be 2 extra credit opportunities. I'm not going to explain it here in the lecture, but if you read the syllabus, it'll tell you exactly what to do and exactly when the extra credit opportunities are available to you. The last super important thing to note is that all assignment exam deadlines are 11:59 p.m. Central Time. So I can tell you right now that the way that the assignments are set up in Canvas right now is that the due date says 11:59, and there was no option to add milliseconds to that, so it means 11:59 and 0 milliseconds. So at 11:59 and 0 milliseconds, Canvas will close the option to upload your assignment or your exam. So what that means is that you should aim to submit everything before 11:59. So that would mean the latest that you can submit something is 11:58 and 59 milliseconds p.m. So don't wait till the last minute. If you try to submit it at 11:59 and 30 milliseconds, unfortunately, Canvas didn't allow that option, so it means like that option won't be there for you to submit. So do it before 11:59. Okay, so with that being said, we touched on kind of the high level points from the syllabus. There are a lot of important things though in the syllabus, including what the actual assignments are, the schedule of dates, so like what readings are due every single week, whether or not there's an exam that week, whether or not an extra credit opportunity is available that week. So all of that is in the syllabus, which is uploaded to Canvas. So please read that, but I wanted to just give a brief overview at the beginning of the lecture. So it was not exhaustive or not all inclusive, so please read the syllabus. Okay, so now that we've gone through that, we're going to transition to talking about the content for week 1's reading, which was reading chapter 1 of the Abnormal Child Psych textbook. So when we think about abnormal behavior, both for child psychopathology and adult psychopathology, we are thinking about behavior that is abnormal and has these following characteristics. So abnormal behavior can be described as something that is atypical, which is something that's odd or statistically deviates from what's considered average or the norm. It's also something that we think is harmful in the sense that it negatively impacts that person's psychosocial functioning. It's causing negative outcomes for them. It's impairing their life in some way. So it's a negative, harmful thing that's impacting their life. And specific to child and adolescent psychopathology, we're also looking at whether or not it's developmentally appropriate. So abnormal behavior in our context is referring to something that's developmentally inappropriate. So it's not following the typical rates of growth or sequences of growth that we know are standard for all children. So what I mentioned a few slides ago in our syllabus slide was that when we look at psychopathology in youth, we're always using normative childhood development as a benchmark. That's kind of our backdrop. So when we're looking at abnormal behavior, when we have concerns about whether or not we see psychopathology in a child, we're looking also at, does this deviate from what we would expect for this child of this particular age group, this developmental phase that they're in. So one thing I pointed out here in the third bullet that I want to also highlight is that abnormal behavior that's just different is not inherently an indicator of mental health problems. So having an individual unique quirk, for example, right, something that makes you different, that's not a sign of mental health problems. What we mean here by abnormal behavior is something that is atypical. So it's like really deviating from the norm in whatever culture or community you're in. It's harmful and it's developmentally appropriate. So all three of those things should exist when we're talking about child psychopathology. So we're not demonizing individual quirks, right? We're not saying it's wrong to be unique. That's not at all what this is saying. This is looking at atypicality. Is it negatively impacting their life? And is it developmentally inappropriate? I won't read this little paragraph at the bottom, but if you're interested, this is also the way APA, or the American Psychological Association website, defines abnormal behavior. So I've already kind of talked about this a few times already, right? But when we're thinking about psychopathology in youth, we're always using normative childhood development as kind of our backdrop, right? This is our benchmark. This is the context that we're working with. So this graphic is a nice example of the things we would expect developmentally for early childhood development. So this is kind of the sequence of growth or sequence of events. We say that generally we expect children to be able to do some of these things in this time frame. And so with this knowledge, we can use this to be able to say, hey, a child is not meeting these milestones. That could be an indicator, right? With the other things we talked about, with it being atypical, with it being developmentally inappropriate, with it being harmful, we can use this sequence and those three factors to be able to say, okay, so it looks like this child is starting to develop mental health problems. So when I talk about sequences of tasks or developmental tasks we think a child should be able to do, that's things like starting to crawl, starting to talk, starting to walk, right? So these are things we know from research, right? Clinician judgment, right? Experience. We know that all children typically follow this trajectory. So when we start seeing deviations from this, coupled with seeing some of the negative, harmful impacts, seeing that it's really deviating from the norm, that's when we start having suspicion of mental health problems. So this was a really nice graphic. It's from the CDC, specifically from the perspective of early childhood development. So we've already talked about kind of the three factors we think about when we're trying to classify abnormal behavior, right? So we're thinking of it as being atypical. We're thinking of it as being something that has a negative impact on the person's life. So it causes functional impairment, or it has negative impacts on their functioning with others, their self-functioning. And then the third piece that we've been talking about already quite a bit is whether it's developmentally inappropriate. So those are the different characteristics or flavors of what abnormal behavior is. But also there are other factors that we need to consider when we're trying to even decide what is typical. What do we mean by something that's the norm? And so these factors include things like culture or ethnicity, so the norms in a certain culture or specific race or ethnicity. We're talking about things like gender norms, situational norms, the person who is having the suspicion about a child being or starting to exhibit mental health problems. So to them, right, they're kind of the referent or the person who's telling us they think that this behavior the child is exhibiting is inappropriate or abnormal. And then the other thing that kind of adds context for how we decipher what's normal or typical versus atypical is just society's view in general, and kind of recognizing that this changes over time. So kind of depending on whatever decade we're in or whatever research is showing us at this time, right? That is the context that we have for defining atypical and typical. So we're going to talk specifically about each one of these in the next few slides. So next week, we'll talk a lot more about some of the specific communities or specific cultural contexts that people are embedded within. But generally, what we're talking about here with abnormal behavior is recognizing that one person does not live in isolation, right? Everyone is embedded in a context. So when we're thinking about what's atypical and what's typical, we have to be considerate and thoughtful about what's the culture that this person is in. So usually when we're having discussions of cultural issues, we're typically talking about ethnicity and race, which I'll give a specific example on in a little bit. But things like recognizing that cross-cultural differences exist, right? So that it's a universal experience to experience mental health problems, but there might be specific cultural differences in how those behaviors or problems are experienced or manifested. So, for instance, this example from the book is that anxiety symptoms can be expressed differently amongst Asians and Latino groups versus European Americans, right? So the example here is that it's a universal issue that all three groups are experiencing anxiety symptoms, but the specific way it's expressed might look a little different in these different ethnic groups. So I can say I know that in some groups, right, there's more somatic complaints versus more of the cognitive anxiety symptoms. So that's one example of how cross-cultural differences exist. Beyond that, there are also expectations within a culture. So there are cultural norms that influence how we perceive behaviors, right? So it helps us to kind of decipher, is something normal slash typical versus atypical. So different cultural beliefs about how children should act, different judgments about children, expectations that that adults have of children, right? Those things color how we define abnormal behavior. So, right, we also know that in the US, this example comes from your textbook, there are different expectations about the capacity for self-control that children have. And that might be different even within the US based on different cultural or racial groups. What I pointed out earlier is that typically when we're talking about cultural norms and culture, these discussions are typically framed around ethnicity and race. And again, the textbook gives a really nice example of how academic achievement from the perspective of a parent is typically viewed differently among European Americans versus Asian Americans. So this is an example of how we're looking at different racial or ethnic groups. And then, of course, I think this point is obvious by this point, but in general, when we're assessing behaviors, it's important because of these things, because we know cross-cultural differences exist, because we know culture impacts how we perceive things, we must be sensitive to cultural norms as we're assessing and treating someone with mental health problems. So gender norms and situational norms also impact how we perceive behaviors and how we determine normality. So with gender norms, it's important to recognize that gender stereotypes exist and they influence our judgments about abnormality, right? So society as a whole, at least in the US, typically views shyness as girls as pretty normative, right? There's less concern when a 5-year-old little girl is shy versus maybe a boy. There are gender norms and stereotypes about young boys being more like lively and very active and expressive. So there might be more concern when a boy is exhibiting more shyness versus a girl. Similarly, there are more expectations that males are going to demonstrate more physical aggression than females will. And so what's important to note here is not that we want to perpetuate gender stereotypes, but to recognize that these things exist and they impact how normality is perceived, and that ultimately impacts who gets referred for treatment and when they do. So, for example, the textbook example about shyness in girls, if a shyness in a little girl is not being flagged as a concern until that child is at, let's say, 13 or 14, and it's the reason why it's being brought up is because now this child has no friends, they're in isolation, they're experiencing depression, their anxiety symptoms have only worsened, right? We're seeing this child now at 13, 14, versus when they first exhibited shyness, which could have been an early sign of, let's say, anxiety. I'm not saying those two things are necessarily correlated, but it's an example of how that child may have had anxiety, but it wasn't really picked up on because there's this gender stereotype that, oh, well, little girls are shy. That makes sense. So, again, this is just an example of recognizing that gender does impact what we think is normal behavior based on the particular sex, and ultimately, if there are problems underlying what's going on, that can influence when we see them for treatment. Similarly, for situational norms, these are also things that impact what we perceive to be normal versus abnormal based on a particular context, right? So based on a particular situation or setting. So what are the expectations for this particular setting or this particular situation, this specific social context that the person is in? And the reason that this is important is because when there are deviations from the situational norm, deviations or violations from what the situational norm is, that can signal to us that this individual might have poor social adjustment, poor social boundaries, right? So something else might be going on. So the example that the textbook gives is the situational norm, right, for running in a playground is very different than being in a library. So it's considered normative, acceptable to be running at a playground, not so much in a library. So again, recognizing that the situation matters that the person is in, and when there are violations of the situational norm, that can tell us that something might be going on. I will say that with social settings, this is something we especially look at when we think about neurodevelopmental issues, things like being on the autism spectrum, right? So if there are certain situational norms, especially in youth, sometimes there are indicators that, oh, this person is behaving differently in this particular context, and that can signal to us there might be some underlying issues going on. The other two things that impact kind of how we perceive normal versus abnormal behavior is who's referring the child, who's the one who's kind of raising the flag and saying, I have a suspicion that this child's behavior is abnormal, is not representative of what I think most children are doing. And so why that matters is because the specific person, whether it's a parent or a teacher or some other professional like a psychologist, they all have different experiences and knowledge of what is typical or atypical. So for example, a parent might say, well, that's normal. I think all 5-year-olds do that, when their context is just their child in their home, or maybe they have a few children and it's really specific to that immediate environment. So that may not be as representative as, say, a teacher whose job is to be around 20, 30 kids every single day, every single year, right? So they might have more of a in-depth, thorough understanding of what children typically present as. And that's going to differ, right, than a professional, say a psychologist who studies child psychology. That person's going to have knowledge of research and their own clinical experience of what children typically present as. So it's important to understand that there are differences in who is identifying and labeling problems in the youth. Because again, children rarely self-refer themselves, right? It's pretty rare that a 4-year-old is going to say, I think I have a problem, or I think I'm having an issue that is not normal compared to others. So that's also something to be aware of, is that the specific informant can be a person who's coloring our thought about what's typical and atypical. And then the last thing is just that we know as a society, there are changing views about what abnormality is defined as. So things are not set in stone, and we know that things change, and that is because we have research. We have research with decades and decades and decades of knowledge and findings, but those things can change over time. So that's why we know that things that are considered atypical now perhaps might not be considered the same thing 30 years from now, but it is possible. And so again, the example in the book is masturbation was originally defined as like a behavioral disturbance in the 1800s, and that's not the case anymore. So again, an example of things can change, and so it's important to be aware of things like that. All right, so we'll transition now to talking about exactly how common mental health disorders are in youth. So what is the prevalence rate of mental health problems in youth? Prevalence rates just refer to how frequently a disorder occurs in the population. So in general, research on prevalence rates for youth mental health problems is mixed. So there's not one specific identified prevalence rate number that has been stuck by, right? There's a range of different numbers. So a couple examples here are in 2015, one study said 13.4% of youth show signs of mental disorder. Whereas another study 4 years later said, with respect to serious mental health problems, it's between 4.8 to 8.9% of youth who experience these problems. This 4.8 to 8.9% range is a little bit different than the APA in 2007 that said it's 10% of youth who have a serious mental health problem, serious mental illness. So again, an example of there are different numbers that have been put out there. They're not high either, right? It's not that we're saying 90% of the population of youth have mental health problems. It is near the lower end. But the point being, mental health problems are not non-existent in youth, and they're worth studying so that we can treat them and assess people early on. The other thing to talk about is why we have different rates. So again, we haven't been able to land on a specific one, but we have general estimates and ranges for mental health problems. And the reason for that is really because of who the informant is and the specific characteristics of the population that we're deriving our population rates from, our prevalence rates from. So when we're saying who is the informant, why does that matter? Well, it matters because self-report versus informant report is going to yield different endorsements of mental health problems. So self-report, let's say a teen, right? A teen can self-report on their own problems. Even a child, right? A 7-year-old could self-report on their problems. That number is likely to be really different from an informant who's reporting on that particular person and those behavior problems. So if you ask a 6-year-old to report on anxiety problems, right, their level of insight is not going to be as in depth, they're not as likely to be as aware of what's going on in them, in their bodies, versus maybe a teacher who's noticing more behavioral symptoms of anxiety in the school setting. A parent is noticing behavioral problems and emotional problems at home that would be representative of anxiety. So depending on who you're getting reports from, that number of mental health problems being endorsed is going to be different. And so that changes the prevalence rate. Same thing goes for the specific characteristic of the population. So if you're asking a clinical sample of people who are hospitalized to report on mental health problems, that number is inherently going to be much higher than just the general population, right? Going to the community and saying, how many of you have mental health problems? So it's kind of this inflated number in a clinic setting because, of course, we know that these people are admitted because they have mental health problems and they're being treated for it. So prevalence rates can vary based on which sample of people you're asking. It can also vary based on the age, and same thing with gender. A couple other things about prevalence rates that the book points out is that most of the research on prevalence rates on youth mental health problems, and remember, there's been disparities in the rates that have been posited out there, but most of it has really focused on childhood and adolescence. So we know a lot less about mental health among infants and preschoolers, and so the book makes a point to say it's just as important to study preschoolers and to know the prevalence rates of these younger children because they occur at the same rate as older children. So that's one thing to be aware of. And then the other thing that the book also talks about is that there's mixed research on secular trends, and all that to say, even then, identification and treatment of mental health problems in youth is important. So I'll stop our prevalence conversation here. I want you to stop the lecture and watch these 3 YouTube videos. I think they're like 30 seconds each. And this just kind of summarizes some of the things we've been talking about with how common prevalence rates are, or how common mental health problems are in the US specifically, and a little bit about how we even start identifying these young patients at risk and what these mental health challenges are that they face. So now that we've been talking about like what are the characteristics of abnormal behavior, what are the different factors that impact how we understand what's considered normative versus atypical behavior, and what are some of the prevalence rates of mental health problems, now it's important to think about, okay, specifically for one individual, right? What are the things we need to be considering when we're looking at the mental health problems of this person? So developmental level is one of those things. So what is the age of the child, and what is the developmental phase that they're in right now? What stage are they in? And why we need to have this information is because, if you remember, one of the things we look for when we're asking, is this abnormal behavior, is this behavior developmentally appropriate or inappropriate? In order to answer that question, we need to know how old is the child and what developmental phase are they in. So again, part of the reason that we're asking these kinds of questions is because there is evidence that some disorders tend to have a particular age of onset. So in the graph, or like this table down here at the bottom of the slide, we see that some disorders tend to appear earlier in life than some other ones. So you tend to see eating disorders, right, bulimia, anorexia nervosa, in adolescence versus the first 6 years of life, right? You're not likely to see a 6-year-old with anorexia, but it makes sense that you would see a 16-year-old with anorexia. So one of the reasons we ask for, considering the age and the developmental phase is because we know that certain disorders tend to trend or cluster at certain ages during the lifespan. So that's one reason. The other thing is that it can point to etiology, help us understand the severity, and ultimately help us with treating and preventing. So knowing exactly the age of onset, which is when did these problems emerge, helps us then look backwards and look at what's been going on, what's the etiology, what's been leading up to this point where the child is starting to manifest and express mental health problems. So having the age of onset can help us kind of look at the etiology, and it also can tell us, wow, this kid has been experiencing this for a while. No wonder it's this severe. Or, oh, we're right at the early beginning. It's less likely that it's going to become severe because we're treating it early on, right? So age of onset is important to know, and also what is the developmental phase based on the chronological age of that child. The other thing to know is that, again, when we think about why is age important to consider when we're looking at specific disorders, is because for disorders that are typically associated with a later age of onset, when we see early onset, that tends to signal to us that there's more severity involved. There's a more severe course that's likely. So the example that we have here is substance abuse or conduct disorder. So substance abuse that we're starting to see at age 12 versus 17, right, points to, okay, there's a more severe course likely to happen. And then the other thing to point out here is that actual onset can occur gradually. It's not necessarily, for some people, you might see a complete switch. Something suddenly happens. But for most, that's often not the case. There's a gradual onset of problems emerging. So I know I mentioned earlier that the age of onset is helpful to know. That age of onset might not be super, super easy to pinpoint right off the bat, right? We kind of need a full developmental history to be able to find that information out. And even then, that kind of just signals to us some of the risk factors that might have contributed to the mental health problems developing. But that's not to say that like one particular event or incident caused the onset of these problems. So these things can actually happen gradually. So gender is also something that we should be thinking about for a particular individual when we're assessing them for mental health problems. So we talked about how gender stereotypes exist, right? There are gender norms for what we perceive to be normal and abnormal behavior. But what we haven't talked about is that there are gender differences in the experience of mental health problems, so the prevalence rates. So those prevalence rates that we just talked about a few slides ago, that was for all youth, but there are also breakdowns based on gender. So across the board, right, there are differences by gender, and this has been observed across time and in many different countries. And what the research has shown is that in general, there tend to be higher prevalence rates for psychological disturbances for boys when compared to girls, but especially for externalizing disorders. So it's really common to see boys come in for mental health evaluations, especially for externalizing disorders. So that's something to know right off the bat. Okay, these gender differences do exist in terms of prevalence rates. The table down here at 1.3 is from the textbook, and it gives an example of the breakdown of some particular disorders that tend to vary based on gender. So things like ADHD, conduct, right, oppositional disorder, drug abuse, those are externalizing problems. So it's not surprising that we're seeing that in this higher for males table. These more internalizing things at the bottom of the table for females make sense. Anxiety/fear, depression, we tend to see those more when we look at prevalence rate of girls. Eating disorders also, it's talked about in your book, but the specific developmental stage also kind of skyrockets the vulnerability that young girls experience and the risk for eating disorders. So that's what this point on the left about important gender differences with respect to timing and developmental change refers to. So once females reach puberty, they're more likely then to become at risk of having eating disorders versus boys who are still susceptible, right? That is still something that boys can experience, but in terms of rates, that's typically a driver of why we see differences for eating disorders. The other thing to be aware of is that although we're saying, yes, gender differences do exist in terms of prevalence rates and the experience of mental health problems generally, right? We also think it's important to recognize that there are also methodological reasons that contribute to why those gender differences exist. So things like research bias, whether or not they're coming from a clinically referred population, and then just in general, this tends to be the case for this type of stuff, is just who's even willing to report on these types of problems. So there are, just like we talked about, there are disparities in the general prevalence rates of mental health problems, and we talked about how Self-report versus informant report is one reason for that. We said the characteristics of the population are a reason for that. Same thing here. These are some of the reasons why we see gender biases in the research. So we might be sampling more males than boys. We might be, males than females. We might be asking clinical populations that have a higher proportion of females admitted for internalizing problems, right? So these are the same issues that are existing in the gender bias prevalence research. All that to say, though, while yes, these methodological issues do exist, right? These are still things that we know to be true in terms of why we're seeing some of these gender biases. Even then, we still know that there are true gender differences. It's not artificial, right? It's not all that there are methodological issues, and that's why we see gender differences. The research shows us that yes, there are true gender differences, and also some of these things do contribute, but that's not all of it. So the take home here is that yes, true gender differences do exist, but also it's important to recognize that some of these methodological issues inflate those numbers. Those kind of drive some of the numbers that we see. Okay, so from this point forward through the rest of the lecture, we're now just going to focus on the historical influences. So what is the early history of the study of child psychology? So I'm going to try to keep it pretty brief and high level, but remember, all of this is in your textbook. So the first point to make is that studying children for the sake of understanding mental health problems is relatively new in the field of psychology. So children were not always a primary interest in either the medical field or the mental health field. So we focused a lot on studying adults and really not so much looking at children. And part of that is because they weren't really seen as being different from adults. There was no interest in the unique developmental experiences that a child has versus an adult. They were just considered tiny adults. And the other thing is that there was also high death rates. So when there are not many children out in the population, there's not as much interest to study them. So that's one reason that just in general, the field didn't start off with a huge focus on children. And even then, when they did consider, mental health problems for children or just children in general, noticing that there are certain deviations, if you will, there were different philosophies about why we were seeing those problems. So things like demonology, somatogenesis, viewing children as either being innately innocent or just evil, like stained with sin. So these were different philosophies and beliefs about how children acted or why they deviated from the norm before we were studying child psychology. It wasn't until the end of the 19th century, right? So late 1800s, that we suddenly started to see a shift in, okay, now children are starting to become an interest. So we have the first publication of a classification system for mental health problems. And so with that, right, there's a more specific movement for mental health in general, and that kind of created the way for a more specialized focus on children. So that's one point. The other thing is that we're starting to recognize that, hey, adolescence is actually a distinct developmental period. They're not children, but they're also not adults yet. So there was some recognition that that's its own unique period. And by the end of this 19th century, some childhood disorders were starting to be identified. So a lot of improvement and progress and growth happening at the end of the 19th century. And then at the beginning of the 20th century, here's when we start to really see developments in our understanding of children and adolescents. So we'll get to that in the next slide. So at the start of the 20th century, we're in the first wave or the first psychological movement. So if you think back to your intro psych class, when you're learning the history of psychology, we typically refer to the first wave, the second wave, and the third wave. So the first wave typically refers to Sigmund Freud's psychoanalytic movement. So it's Freud and his followers. And this is really the first modern systematic attempt to understand mental disorders in psychological terms. So this is really the starting point for psychology as a whole, but also for child psychology in particular, because Freud's beliefs really point to the importance of early childhood as a developmental period to be looking at in terms of causing mental health problems or being at least a risk factor for why we have mental health problems. So in Freudian theory, he talked a lot about underlying unconscious, unresolved psychological conflicts and crises from early childhood as being the source of emotional problems. So the point really to take away from this and how it relates to child psychology is not necessarily the specifics about whether there's unconscious or conscious representations. That's not the point I want you to take away from this. It's really that Freud is among the first in early psychology to point out that we should be looking at early childhood, that childhood in and of itself is a sensitive period, and things happening in this period can be a risk factor for emotional problems for adults. So that's really the take home here. Of course, we can't talk about Freud without talking about the different structures of mind, so the id, ego, superego, and the defense mechanisms that are thought to develop as a way to manage these conflicts that arise. The other thing that we, of course, talk about when we think about Freud is his idea about the psychosexual stages of development. So his whole thing about conflict and unresolved conflict in childhood relates to when a child goes through these certain developmental stages, which he calls psychosexual stages. When a child does not resolve whatever quintessential conflict is supposed to be happening in that stage, that then leads to psychological problems. So he says that there are 5 stages: the oral, anal, phallic, latency, and genital stages, and that when a child is unable to resolve the conflict within the oral stage, for example, you see problems related to that happening. So just like the point I made in the earlier slide, the specifics about the psychosexual stage is not what I want you to take away from this. It's really that, again, childhood is a critical period and we need to pay attention to it. The other thing to take away from this is that, of course, there were many controversies about analytic theory. There was not as much empirical basis, right? A lot of it was clinical observations that Freud was making these theories based off of. So this makes it difficult to test. So yes, it's important to acknowledge that there were many controversies of analytic theory, and that's why we moved into the second wave and the third wave, which we'll talk about. But we also want to acknowledge the major contributions that psychoanalytic theory has for modern day psychology and child psychopathology in general. So an important point to make too is that yes, there are currently traditional psychoanalysts that still exist, but overall psychoanalytic theory has also evolved. And so the modern view of psychoanalysis has much less emphasis on sexual forces and much more focus on the social influences. And so that still draws on original psychoanalytic theory, because Freud talked a lot about the parent-child relationship, talked a lot about mothers and fathers, not so much peers, but just the idea that there are social influences that impact psychopathology. That is huge, especially for child psychopathology and developmental psychopathology, which we'll talk about next week. So that's one thing that has been refined a little bit more in terms of modern day view of psychoanalysis. A couple examples of what would be considered modern psychoanalysis is Anna Freud's object relations theory, which really focused on children. Erik Erikson he kind of shifted from the sexual stages, and his theory was about the psychosocial stages of development. So that's also born out of psychoanalysis, but not necessarily psychoanalytic in and of itself. And then modern day view of psychoanalysis really pays attention to underlying mental processes, childhood experiences, and parent-child relationships, which is crucial when we're thinking about psychopathology. So again, it's important to note that yes, while there are many controversies of Freud and his analytic theory in its original form, there's still major contributions for psychology today, and especially child psychology. So again, like parent-child relationships, childhood experiences, those are key to understanding psychopathology for youth. Again, here's another note here. One way that this contributed to psychology for children is that it provides a framework for understanding child, adolescent, and adult behavior. And it added psychiatry as a discipline with a child emphasis, I think, because Freud was not a psychologist. He was a physician. So that's another thing to consider. So we just talked about the first wave of psychology, which was the analytic movement. Now we'll move into the second wave, which is behaviorism. So because of the controversies of analytic theory, which was that there was no empirical basis, there was no way to test the theories that Freud had at that time, there was a movement towards a more empirical behavioral model. And so with that, we have behaviorism and social learning theory. So there's a lot of text on here. I'm not going to talk about it. Not going to talk about it in detail. The idea here is that John Watson was the first to introduce behaviorism in the US. So here we're getting away from the developmental stages and psychological conflicts that Freud talked about, and instead we're looking at the learning environment. And we want to test these ideas through experimental methods. So the key belief here, the key concept here is that all behavior, adaptive or not, is explained by the learning experience. So what is it in the environment that is reinforcing the behavior to occur? So we, of course, had Pavlov with classical conditioning, right? So that's one example of how behavior is learned through conditioned or classical conditioning. We also have Thorndike's law of effect, which is that behavior is shaped by consequences. And this is a key principle in learning theory. So that also comes out during this phase. And then also we have B.F. Skinner and his theories about operant learning. So this was really the application of shaping behavior by applying behavioral consequences. So we need the environment and we need to have reward and punishment to modify our behavior. And then we also have social learning theory with Albert Bandura. So this is different from classical conditioning, right? That's one aspect of behaviorism. Social learning theory kind of does a bridge of both some of the reinforcement from the environment and just the idea of classical, just modeling, observing from the environment plays a crucial role in behavior forming and in learning those behaviors. So you can think of the classic Bobo doll experiment where these kids viewed their parents being really aggressive towards this Bobo doll. When they viewed their parents this way or acting towards this way towards the doll, they were more likely to be aggressive. And when their parents were not aggressive towards the doll, the children were then less likely to be aggressive towards the doll. So the take home here is that in the field of psychology, there was this behavioral wave, and these principles are also very important for child psychology, especially when we're talking about treatment of certain psychological disorders for kids. So the application of learning principles in treatment include this cognitive behavioral perspective, that there are learning principles and social context and thought that all play together to impact how we act. And if we know that that's how behavior is formed, that's how thought is formed, then we can target that in treatment. And same idea with behavior modification. So the mental hygiene and child guidance movement is more about treatment of individuals with mental health problems. So it was more about mental health reform, and we'll talk about why that's important for child psychology. But I want to point out that we're talking about this particular movement in history for a different reason than we were with analytic theory, right? Because that was more about just historically, what are the theoretical and empirical, well, not empirical, but what are the historical influences of why we study certain things in child psychology. We were talking about behaviorism because that's also another theoretical lens that we care about when we think about behaviors in children. And that in particular also was helpful for informing our treatment of certain childhood disorders. But now we're talking about mental hygiene and child guidance movement because this was important for the way that we treat people with mental health problems and the certain reforms and laws that we have in place to ensure that people are treated properly. So prior to the mental hygiene movement, treatment really considered of just being institutionalized, being put in these asylums, which most of the case were unsanitary and really horrific. So the mental hygiene movement really aimed to improve the treatment of people in these institutions and really try to get them out of these institutions and get them better care. So an offshoot of that, or kind of a result of this mental hygiene movement, was the child guidance movement, which began in the late 1800s and really focused on children with educational problems and trying to assess and treat them. And then it later also tried to address the antisocial behaviors and emotional problems. Scientific study of youth, though, so here's where the empirical stuff comes into play. That really was kind of propelled forward by three people in particular, or three groups of people in particular. So Stanley Hall is one important figure who collected data on youth to study youth problems, and he helped to establish the APA, American Psychological Association, and he served as the first president. So empirically, that's a huge milestone, right? Collecting data on youth. Binet and Simon it developed the intelligence test and determined which French children would benefit from special education. And then Gesell really meticulously studied and tracked children's physical, motor, and social behaviors in order to create developmental norms. So remember, we've been talking about developmental age. We talked a lot about norms. So this empirical data collection of this type of information was really important. All right, so we have talked a lot about defining abnormal behavior, what is the prevalence rate of mental health problems in kids, and we just finished a really brief history of psychology with a more particular focus on the historical influences on child psychology. So we'll wrap up with just talking about some of the considerations that are made when working with children in research and in clinical practice. So who works with kids? So there are many professionals that work with kids. They can be people like psychologists, physicians, master level clinicians, teachers, etc. So there are many adult professionals that can be involved in children's lives, and that's going to be important as we move into next week and we start talking about environment and the different contexts that children are in. So keep that in mind as you start reading for next week. There are special considerations that need to be made when we're working with children, adolescents, and their families that are pretty unique to this population that people working with adults don't necessarily need to think about. So one example is that working with children tends to foster interdisciplinary collaboration and coordination. So there are many different professionals that work with children that might be involved in one case. So, for example, I might be seeing someone clinically for an eating disorder, right? I'm their therapist for this mental health problem. But also because it's an eating disorder and that involves their physical health, I might need to collaborate with their physician, right? The person who is in charge of their diet plan. Maybe they have a dietitian and there's the physician, right? The primary care physician. And this person, let's say they're purging, right? Maybe the school counselor is involved because the child is purging at school when they're anxious or what have you. So I just listed several different people that might be involved in this person's life. And it's probably necessary that we all collaborate together. So this is an example of many different people or adults in a child's life that could be collaborating for this person's care. We also work really closely with parents, and this especially is the case when we're working with younger kids. So a lot of times treatment for younger kids tends to be behavioral, where the parent is learning a lot of strategies to enforce with their children. And so we do work really closely with parents. Even with adolescents, right? We give adolescents typically more agency because they're getting closer to adulthood, but the parent is also still key, right? They live with their parent most often. And so it's important to continue involving the parent. It's also important to have knowledge of and be sensitive to normative development and the developmental issues. So if you're going to be working with children and adolescents, if you're working with, for example, I don't know, a 3-year-old who's still being potty trained, it's important to know, is that in line with the developmental phase of potty training, the developmental milestones of potty training? So knowing what stage they are typically in, knowing what issues typically come up. So another example, right, if we're talking about people in adolescence, if you're working with a teen, you're probably going to hear a lot about their friends. They're going to be talking about, they might be talking about alcohol and drugs and sex. And so those are things that are coming more online for people of that age versus, right, you're not going to hear that talking to a 4-year-old. So it's important to be aware of the norms that occur developmentally, and also to not be squeamish, right? So you have to be sensitive to what's going on in that phase. In any therapeutic relationship, adult or child, it's important that you're creating rapport, right? There's a bond between the therapist and the client. But there's special effort and consideration that needs to be made when you're working with the kid. And that's because there's a complicated relationship where the parent is the legal guardian, whether it's a parent or the legal guardian, the adult in their life is the one who makes the calls. They are the ones who sign the consent form when they attend treatment. So it's really important that as the therapist, we're spending a lot of time trying to develop that rapport and emphasize that this is, private, this is confidential, but also there are certain limits, and that's because you're a minor. And so you explain to them, here are the limits, here's what I can talk to your parent about, here's what I won't talk to your parent about without your permission. So that brings me to what are the ethical standards of working with children. So you have to get informed consent from the legal guardian. You can't work with a child without getting consent. Children don't give consent. They can provide assent, but that's not necessarily required for therapy. So you have to have consent. Children can't give consent to begin with. They can give assent, but that's not required for therapy. What I was just saying in terms of trying to establish rapport, something that's tricky is having to explain the right to confidentiality. So yes, while there's confidentiality and the specific details of what we talk about, I won't share with anyone else, there are exceptions to that rule. And that's if I feel like the child is going to hurt themselves, if they're at risk of being hurt by someone else, if they're going to hurt themselves or anyone else, if I suspect child abuse or elder abuse in the home, those are exceptions to confidentiality, and that I would have to break confidentiality and share specific details. So it's important that when you're working with kids, there are special efforts made to establish rapport, but also balance that out with your ethical obligations. So here I included a little video of what that could look like with working with the minor. Okay, so that concludes the week 1 lecture. A lot of that, again, covered what was in the textbook reading. I will say the next few lectures is pretty split, right? So there's going to be stuff from the textbook, but there's also a lot of stuff not from the textbook. So I'm plugging this here at the end of this lecture that even though this lecture had a lot of stuff from the textbook, I would encourage you to keep watching the lecture recordings because I will be talking about things that are not covered in the textbook, and these things are going to be helpful for assignments and exams. So with that being said, here's the weekly to-do list for the week. Review the course syllabus. I know we talked about some of the high-level things at the beginning of the lecture, but again, it's very detailed, so please read it. You'll also want to complete your Chapter 1 reading from the textbook. And then I also want to make a note that the optional syllabus quiz is now open. If you have any questions about the syllabus quiz, go read the syllabus and it'll tell you what it is and why it's optional. And for next week, we have both Chapter 2 and Chapter 3 as assigned readings, and we'll be focusing on developmental psychopathology, the framework. So thanks for tuning in. I will talk to you guys next week.